All right, thank you for the introduction, Stacy. Just wanted to again welcome everyone and thank you all for joining this evening. This is the February 2024 Pain Science Lecture Series, and I'm honored to give my presentation to you all today. Just as a brief introduction, my name is Trey. I'm from Pennsylvania, and I studied neuroscience at the University of Pittsburgh. I then went to West Virginia University in Morgantown for medical school and received my anesthesiology residency degree there. I then joined the wonderful staff here in Palo Alto at Stanford for my pain fellowship. So my presentation today will be focused on the neuromatrix of pain and some of the ideas and explanations that led up to this explanatory model of how we now think pain is processed, and therefore how that has helped us to develop different therapeutic options for our patients. I want to start by setting the stage a little bit with these two separate images. And I'm going to have you all just take a moment to picture these kind of one at a time in your mind. I want you to think about your personal experiences of either of these happening to you. If you've never been hit by a baseball or softball while you're at bat, I'm sure all of us have stubbed our toe at one point on a chair at the table in the kitchen. But we can start by the left image. I want you all to just imagine you're playing baseball and you get hit by a baseball or a softball. Picture yourself in this situation and think about what you might immediately feel. Then I want you to think about what your immediate reaction would be, or what would you do? Finally, what would you be thinking in this moment? Next, think about you're running to first base now. What do you hear people saying to you as you're running to first base? Transitioning to the second picture, maybe a little more common everyday occurrence for us. Picture yourself, normal day, you're walking in the kitchen, you accidentally kick your toe against the table or a chair. Again, just take a moment and think about what you would feel, how that would feel, and what coping strategies you think you naturally or instinctually have developed to kind of get you through this short period of a very painful moment. We're going to come back to these pictures in a little bit after we further discuss some of the science behind pain and how it really influences our everyday behaviors. Before we get into the details of the different theories of our current understanding of pain, I just wanted to start very simply by briefly talking about pain in general and looking at the most current and up-to-date definition of how we define it. So what exactly is pain? So this is the current definition listed as the first bullet point there. It is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. This is a very interesting definition for two reasons that I want to point out. The first, you'll notice that pain is both a sensory or physical experience, which is what we more naturally think of as pain, but it's also an emotional experience. The second interesting point of the definition is that there can be actual tissue damage. For example, you're riding your bike and you fall off the bike and you scrape your arm. There's actual skin tissue damage there that's painful. Or pain can be potential or the threat of potential tissue damage. I like to think about this is, okay, you've already fallen off your bike and you have a big scrape on your arm. Maybe the next day someone accidentally bumps up against you, and normally you wouldn't think twice about them touching your arm, but now you're almost hypervigilant, or you almost elicit a painful reaction to something that is really not dangerous. The other thing about pain is that is a very personal experience. That is, we all experience pain very differently. It's determined not only by our personal biology and genetics, but it's also determined by different psychological and social factors of our life experiences. And just a point of definitions, I will be referring to pain and nociception throughout the talk. And I just wanted to take a second to note that these are two different things, and I wanted to highlight that here. Pain cannot be inferred solely from activity of the nervous system or neurons. Nociception refers to the actual physiological process and activation of neural pathways that are damaging tissue. Pain, on the other hand, is the subjective experience that one feels as the result of nociception or the activation of these pathways. So getting more into the details of what is the point of pain, or what is the point of acute pain first. So acute pain serves a very important protective role in all of our lives. It's designed for you and for me to detect tissue damage to protect us. And this helps to drive behavioral changes, which are essential to survival. Two examples that I put on this to kind of help us think about this topic. One is on the right side. We could think about when we were young, we all started out life really not knowing that certain things are dangerous to us or not. And we had pain there to teach us these certain avoidant behaviors. So for example, when you were young, you might have touched a hot pot on the stove at one point. However, the odds of you doing that a second time are way less because that painful experience taught you that this is not something that's healthy or good for my body. Another example that I think makes it really easy to understand, and this is an example of how powerful the pain response is and how we can use it to keep ourselves and our loved ones safe. If any of you have a big yard and a dog that uses an electric fence, if you ever think about why does this work so well to keep our dogs in the yard? This is my dog, Jet, and he had a big yard to run around, and we installed an electric fence so that we could let him out kind of to go wherever he wanted, and we didn't have to worry about him running away. So your dogs learn not to cross that line. Why do they do that? It's because they don't want to go through that painful experience again. And for example, Jet, one of his favorite activities in the world was chasing deer in our backyard that he could see from our porch. However, after just a few unpleasant experiences with him crossing that boundary, he learned to stay in the yard. He had an invisible boundary that he knew he didn't want to experience again. And just that was enough to keep him from doing one of the things that he really, really enjoyed and one of his favorite things to do in life. I think it demonstrates how painful that our memory of pain can be and how important it is in driving our behaviors. So I wanted to transition this into chronic pain. And we just talked about acute pain. So what is chronic pain exactly? And what are the differences between chronic and acute pain? So we usually look at about the 3 to 6 month point where pain starts to become less advantageous to keeping us safe and more of a liability to our day-to-day lives and enjoying things that we like to do. Now, this has to do with changes that take place all along the anatomical pain pathway, which we're going to talk about in a little bit. Basically, all the way from the peripheral nerves in your fingertips and skin, all the way into your spinal cord, into your brain. And this is the result of basically our nervous system reprogramming, which is also called neuroplasticity. And this chronic pain can result from a wide range of conditions. For example, arthritis, direct injury to nerves, a herniated disc in your back, fibromyalgia, or persistent headaches, just to name a few. It can affect different parts of the body, and it can vary in intensity from mild to severe. Chronic pain not only causes physical discomfort, but it can also have significant psychological and emotional effects, impacting our mood, our sleep, our relationships, and really our overall quality of life. Just like pain can affect these things, our mood, sleep, relationships, and quality of life can influence how we feel chronic pain and the severity of which we feel it. One of the examples I like to give to patients is that if you have two people with the exact same back injury, you get an MRI, they have the exact same pathological issue in their back. The first person you can think about as having a generally pleasant mood, getting 8 hours of refreshing sleep a night, having good relationships with their family and friends and a great support system. And you compare that to the second person, maybe who is lacking in one or more of those categories. The person lacking in one or more of those categories generally could be experiencing worse or severe chronic pain. Well, why is that? What has to do with this concept of the neuromatrix that we're going to talk about the further we go in this talk. And basically, that comes down to everything being added and summated in our brain to get an output. This is a really important slide that I think we can all keep in mind as we go for the rest of the discussion. It's basically a map of where we can have injury to our nervous system and where we can experience pain. And that's helpful because ultimately that can tell us where we can therapeutically fix the pain. As the years went by and we understood more and more about pain, we also started moving up this pathway with different treatment options, kind of starting all the way at the periphery and then working our way towards the brain or the central nervous system. This pathway, these are the physical mechanisms of pain perception and the normal pathway of how our nervous system processes painful signals. And I think that this will just help to set the stage so that we're better able to understand the neuromatrix theory of pain and how we can use that to our advantage to help us manage and treat patients. So when we think about this pathway in detail, there are generally 4 steps from a nociceptive signal getting from our environment to us feeling the experience of pain. And that starts with transduction. What transduction means is the process by which a stimulus from our environment activates the nerve endings in our fingertips or our skin. This leads to step number 2, which is transmission. Transmission refers to the relay functions by which this electrical signal gets from our periphery and is carried all the way to the spinal cord and then to the brain. The third step here is modulation. This is a particularly important step in our talk because we're able to affect a lot of modulation to help treat patients. So modulation means how our body can alter the signal as it goes from the periphery all the way to the brain, or likewise how a signal will go from the brain to the periphery. And finally, the last step in our experience of pain is what our perception is. And again, this will be the subjective awareness produced by all of these sensory signals adding up together. And it involves the integration of many different messages into a coherent and meaningful whole. We're going to talk a lot about these last 3 steps. And this slide I like to kind of remind me of the specialty of anesthesiology in general. I think an easy way to think about this is a lot of people can think about orthopedic surgeons and how they're kind of the carpenters for our body. So if you break a bone, they're able to fix that break and put the bone back together. I like to think about anesthesiologists and pain physicians more of the electricians of the body. So we're working on the electrical signals that go all over your body and how we can modulate those to help ease pain and suffering. So as I mentioned in the 3rd bullet point, modulation is a very important step in this entire process that we can kind of target to help with therapeutic options. So I just wanted to spend just one more slide on this topic in particular. So modulation is the process by which the body alters this painful signal as it is transmitted along the pathway. Interesting, it can be either excitatory or inhibitory. So as it goes, it can make itself worse before it gets to your brain, or things can calm it down before it gets to your brain. And this can occur at many different levels along the process. It can occur in the periphery. It can occur once the signal hits the spinal cord. It can happen when it's in the brain stem, which is the bottom of the brain, or it can change in the brain itself with our thoughts, memories, and emotions. And modulation explains, at least in part, why we all have individual responses to the same painful stimulus. This leads me into kind of the highlight of our talk, which was the neuromatrix of pain. So how did we get to the neuromatrix? Some of the leading theories prior to the neuromatrix, I think, helps to understand how we got there. So I wanted to briefly talk about 2 of the simplest ones that we talked about early on. The first was the pattern theory, which said basically all the nerve cells in our body were the same, and it was just a matter of which ones got stimulated, the pattern of which that went to the brain and produced a response. Well, since the pattern theory, we learned that this can't be entirely true and this can't entirely explain pain because we discovered that there are all different types of nerves and all different types of nerve endings. And that's what this picture on the right shows, just showing 4 different types of neurons that live in our skin and live in our tissue. Once this was discovered, one of the next leading theories was the specificity theory. So that basically said, okay, we know that there are different types of nerve fibers, and instead of it just being which ones are turned off or on, it's which specific ones are turned on and off, and the pattern of which those determines your painful experience. Well, then we learned that this doesn't quite work either, and it doesn't quite explain everything. And I can give you a few simple examples that kind of make that easy to understand. I think the easiest one that refutes these as not explaining the whole story are the example of phantom limb pain. So phantom limb pain is the experience of feeling pain in an extremity that is no longer there from an amputation surgery. So there's no nerves there, there's no nervous tissue there, but people have the subjective experience that, for example, they had an amputation of their left leg. They can feel pain in their left foot sometimes. So there's nothing there to cause a signal to go to your brain, but they're still experiencing that phenomenon of feeling pain in an extremity that's not there. Another example is that sometimes non-painful stimuli can be painful. And that's kind of goes back to the example I gave on scraping your arm from falling off your bike. Just being touched in that area after an injury can be much of a more of a painful experience than if you did not have that painful experience previously. Final example of this is sometimes we see pain that spreads in an unpredictable way to other areas of the body that really have no reason to have pain or no pathology. An example of this is, say you had abdominal pain that would require you to get your gallbladder out. A lot of people may have referred pain from this to different areas of their abdomen or even their shoulders. These 2 theories of pain eventually led to what Robert Wall and Patrick Melzak coined the gate control theory. So this is just one more step further in our understanding of pain and how it's processed by our brain. So the basic tenets of the gate control theory were that you have these nociceptive or painful signals and non-nociceptive or non-painful signals that are kind of summated and added up as they go along to the brain. So whether that be in the spinal cord or the brain, they add together to equal an output. I think an easy way to think about this is the picture on the right is a flock of sheep, and they're all trying to get through a small gate at the same time. So you can think about this being the nervous system and a bunch of different nerve signals trying to get into the spinal cord and the brain at the same time, but only certain signals are able to go. So the gate control theory basically means if someone experiences a painful stimulus, we've found that the application of a non-painful stimulus can help to activate this gate control mechanism and reduce our painful experience. So on one hand, if the gate is open, the signal passes all the way to the brain. But on the other hand, if the gate is closed, that pain signal is restricted and it's not able to make its way to the brain for you to have that painful experiences. There are many factors that influence this, including the neuromatrix. The factors include physical things, emotional things, and cognitive factors. So it's not only from the periphery to the brain, but the brain can also send modulating signals back down the pathway the other way. This is a really busy looking slide, but I'm going to walk through it with you just to kind of hammer home what exactly the gate theory means. So I want everyone to focus on the left side of this image for now. The C fiber is another word for a nociceptive fiber or a fiber that transmits pain. The A beta fiber is an example of a nerve ending that senses touch or pressure in our body. So on the left side of this picture, The only signal that is firing is the painful C fiber. So this would like be getting your hand close to a candle and you feel the temperature from that candle and it's painful. And you have nothing else firing in your body. So there's no touch, there's no other sensations there. So the painful signal is able to go all the way from your skin to your brain. Looking at the second part of this system here, what happens if we add all of these together? So the one example I'll go back to for this is getting hit by that baseball. So you have the painful signal going to your spinal cord, but now as you're running to first base, what's the first thing we instinctually think to maybe do or feel? The first thing I think about is putting my hand over my arm and kind of rubbing the area. And why do I do this? Well, this activates those other pain fibers in our body, such as these alpha beta fibers that are able to fire and ultimately close this gate somewhat so that the painful signal is not able to get through. So all of these theories kind of summarize to our current understanding of pain, which was coined the Neuromatrix, also by the same group of people from the previous slides. The Neuromatrix is much more of a top-down approach to our understanding of pain, and it says that pain is primarily produced by the central nervous system, which means the brain and the spinal cord. And it's multiple parts of our brain and spinal cord that work together to create our experience of pain. This shifts those previous ideas more from a peripheral to a central origin of where we feel pain. And it has great implications because it gives us more avenues to treat patients with more effective strategies that can target the CNS and not just the periphery. One example of this is cognitive behavioral therapy, which I'll spend a whole slide on later. But one part of cognitive behavioral therapy is what's called cognitive restructuring, which is a technique aimed at identifying and challenging negative thoughts or negative thought patterns and recognizing and changing our irrational beliefs or our distorted thinking that contribute to an emotional distress or problematic behaviors from that. So basically, individuals learn to replace unhelpful or inaccurate thoughts with more realistic and balanced ones. And by doing this, they reduce negative emotions and they improve their coping strategies to deal with pain. So this technique helps individuals develop a healthier and more adaptive way to interpret and respond to various situations. Another example of the neuromatrix working for pain is the placebo effect, which we see in all different types of scenarios and all over different specialties of medicine. So basically what the placebo effect is, it's a patient experiences an improvement in their symptoms. We'll use pain to keep it easy. So they experience an improvement in pain after receiving a treatment that has no real therapeutic effect on the condition. This would be an example. You have one group who takes a known medication that helps pain and another group that takes a pill that just might be sugar. And we actually see in the group that doesn't take the actual medication, they still get somewhat of a benefit from that. So why is that? Well, it has to do with this neuromatrix of pain and how powerful our thoughts are. Another example of the neuromatrix that I can relate to our specialty of anesthesiology is one of the most common anesthetics we use every day in the operating room is what's called propofol. And most of you have probably heard this medicine before. So propofol is very interesting because it's an amazing sedative, meaning it puts us to sleep very quickly and it keeps us nice, calm, and comfortable. It's also an amnestic, meaning it helps us to not remember the experience. It's also an anxiolytic, which means it helps to decrease our anxiety during that entire period of surgery or time. What propofol isn't mechanistically is an analgesic, meaning it has no painful reducing properties on its own. So why then, if you got a propofol anesthetic for a surgery, you really don't experience pain, you don't have a memory of an unpleasant experience during the surgery? Well, that's because it taps into the neuromatrix in our brain. It's able to decrease our experience of pain in different ways. Another easy example to think about the neuromatrix from a spinal cord standpoint is when we're doing a C-section for a patient having a baby. So one of the most common ways to provide pain relief for these patients is to do what's called a spinal anesthetic, which is when we inject a little bit of medicine that bathes the spinal cord. So these patients are wide awake during their C-section, but they don't experience any pain from the operation that's occurring in real time. And that's because we're able to modulate the spinal cord sensation so that so that they don't have to experience pain. So I wanted to get back to this picture now that we've had some time to think about these different mechanisms and the science behind pain and why we instinctually or naturally have some coping strategies inherently built into us. So as I mentioned for the baseball example, one of the things that you'll see people do all the time is they'll rub the area that's injured. And what they're doing is they're closing that painful gate so that the touch or the pressure is going through instead. And inhibitory neurons are decreasing the painful stimulus from that baseball. And the same thing with stubbing your toe. The first thing I think of when I stub my toe is dropping down to the floor and kind of grabbing your foot and massaging it or rubbing it. Because ultimately, this really does make the experience feel better and make our foot feel better. Now I want to change gears a little bit to focus on now that we know and have this information about the neuromatrix of pain and how pain signals are processed and how our brain can help, how do we use these for different therapeutic options or use it to our advantage for different treatments for our patients with acute or chronic pain? So we can think of really three separate areas where we can do this, all the way in the periphery, such as in your hand in this picture, at the level of the spinal cord, or all the way up at the level of the brain. I'm going to talk about a few of these examples in the later slides. So in the periphery, you can think of physical therapy, occupational therapy, radiofrequency ablation, or peripheral nerve stimulation. All of these therapies work on the nervous system all the way out in our fingertips and nervous system. The spinal cord is another target. So we're going to talk about a little bit about spinal cord stimulation and how this works. Dorsal root ganglion stimulation is another option. And finally, we're going to, at the end, touch on different ways that we can affect pain at the level of the brain. So this looks like pain psychology, cognitive behavioral therapy, and relaxation techniques, just to name a few. And the interesting thing that we have found, and one of the ways that we focus on pain relief at Stanford, is a multidisciplinary or multifaceted approach. So we think people have better outcomes if we're using multiple different treatment strategies to help them. So instead of picking one medicine, we might use one medicine in combination with an injection or procedure in combination with physical therapy, in the hopes that all of them together help to decrease the pain more than any one treatment alone. The next few slides, we're going to focus on neuromodulation and some of the things that we do from a procedural standpoint in our clinic to help reprogram the nervous system, as I was mentioning before. So neuromodulation treats chronic pain by modifying the activity of our nervous system in a very targeted fashion. So we've developed technology that's able to act directly on specific nerves. And it works by altering or modulating nerve activity by delivering electrical impulses directly to a target area. And as I mentioned before, this used in conjunction with physical therapy, psychology, and medications can really help to restore functionality for someone struggling with chronic pain. Probably the most common example and least invasive examples of neuromodulation that many people use is what's called a TENS unit or a transcutaneous electrical nerve stimulation. This is a very non-invasive neuromodulation technique, and it works by using low intensity electrical currents through electrodes placed on the skin. What's nice is it's over the counter, meaning you can get these on Amazon or Walmart or a pharmacy. and they're just little sticky pads that you can place directly on a painful area. These pads placed on the painful area give off electrical impulses that stimulate the nerves, and they can help to relieve pain. So kind of going back to the gate control theory, instead of just a painful signal going from that area, you now have a small electrical buzzing sensation plus the painful stimuli, which they can act on each other. Another example of a neuromodulation option that we use in the clinic fairly frequently is what's called peripheral nerve stimulation. So this is treatment of the peripheral nerves, again, with electrical impulses. And it's really most helpful when we're able to distinctively identify a particular nerve that is causing the issue. So this is why it's really helpful when we maybe see you on our video appointments, and before we're able to make a decision on what the next step in your treatment is, a lot of the time we'll ask you to come in for an in-person visit. And that's because we want to determine what exactly nerve is involved. So we may be able to give you another option. Radiofrequency ablation is just a one-time spot treatment of the peripheral nerve with an electrical impulse. A temporary or permanent peripheral nerve stimulator implant is when we actually place a small wire right up against the nerve, and we're able to use an electrical stimulus to buzz this nerve to neuromodulate the system and give you pain relief that way. The last neuromodulation technique that I wanted to mention is a spinal cord stimulator. This is a little slightly more invasive, and this is when we place electrodes that we surgically implant into the epidural space so they can stimulate the spinal cord instead of the peripheral nerves. So all the device consists of is a few wires and a small pulse generator. It's about the size of a pacemaker, if you know someone with a pacemaker. And it works by delivering a mild electrical impulse, just like the peripheral nerve stimulator, to the spinal cord itself. And these electrical impulses interfere with the transmission of those painful signals to the brain. So this essentially can block or modulate that peripheral sensation of pain to our brain. This goes back to the gate control theory, as we talked about before, the interference of the painful signals. There is paresthesia and subperception stimulation, which means for some people, when they have a spinal cord stimulator, they constantly feel a small buzzing sensation in the back. But for others, there's subperception stimulation, which means they don't feel anything, but the spinal cord stimulator is still on and stimulating to help alleviate their pain. The last great thing about these is their individualized programming, meaning you work one-on-one with the representative who's able to individually program the electrical output from the stimulator to give you the best pain relief possible. So you could put the same exact spinal cord stimulator implant in two different people who have different pain, but you can program it in two different ways so it optimizes their pain relief. So what are the benefits of these procedures that we do? Number one, it can give you long-term relief. Other treatment options might be only short-term. It can have sustained pain reduction and functional improvements, and it can help patients do their daily activities. Again, it just works on expanding our treatment options. So it expands the range of the different options we're able to provide to patients, and it can be used, as I mentioned, in isolation or in combination with other treatments. And this really allows your pain doctor to customize their treatment plan to you. These are reversible at the end of the day. So if your pain improves with time, we can always turn the stimulation off or remove it. And it's adjustable, so we can personalize it exactly to tailor the patient's unique needs. And we do that by changing the frequency, the intensity, or the duration of the electrical output. And finally, neuromodulation is really nice because it gives us another tool that's a non-drug treatment option, and it's very targeted and specific. So it really reduces your reliance on any one other particular therapy, such as a medicine. So instead of taking 2 or 3 medications to help with your pain and dealing with the systemic side effects that may come from those, you may only need to take one or no medications because you have a neuromodulation unit that's able to help with your pain. And this goes to the really targeted approach of neuromodulation and overall, goal of reducing the systemic side effects to the rest of your body. I want to end on this slide on cognitive behavioral therapy. So you may have noticed we have been working our way from the periphery with peripheral nerve stimulation. And then we got to the level of the spinal cord, and we talked a little bit about spinal cord stimulation. And finally, we're making it all the way up to the brain with cognitive behavioral therapy. This is a really good graphic, I think, explains it very easily and in layman's terms. But basically what it is it offers a holistic approach to managing pain by addressing negative thought patterns, behaviors, and coping strategies. I gave you a brief definition of what exactly it was, but I wanted to talk a little bit about the specifics of it and what we actually do with cognitive behavioral therapy. And one of those is with cognitive restructuring, which we talked about. Another one is with behavioral activation, which encourages individuals to engage in activities that bring them pleasure or joy or a sense of accomplishment, even when they really don't feel like doing that because of their condition or mood. Another really common one are relaxation techniques. So these are a set of practices used to induce a state of relaxation and reduce stress and tension in both the mind and the body. Examples of relaxation techniques are deep breathing, progressive muscle relaxation, guided imagery, mindfulness, and biofeedback, just to name a few. The last just piece of cognitive behavioral therapy that I wanted to mention is graded exposure. And what that is it allows individuals to gradually confront and overcome fears or avoidant behaviors related to specific situations or stimuli. An example of this is a painful condition we see a lot is complex regional pain syndrome. And these people develop a real sensitivity to even light touch. And one of the best strategies to help these people is with what's called desensitization, and that's through graded exposure. So maybe the first week, they're just lightly touching the painful extremity. The next week, they're able to put a sock on and leave their sock on for a period of time. And then the following week, they're able to put a sock and a shoe on and then walk, a few blocks. So with time and exposure, we see that that's helpful for patients. And cognitive behavioral therapy, at the end of the day, is tried and true. There are numerous studies demonstrating its effectiveness in reducing pain intensity, improving function, and decreasing the reliance on medications. And it can, as mentioned with the other therapies, just really complement all of the other interventions and enhance people's self-management skills. So in conclusion, the Neuromatrix really helps us to understand the complex and multifaceted nature of pain. And it also allows us to treat patients through multiple different ways and multiple different approaches that all complement each other. And with that, I'll send it back to Stacy for any questions.